I've lived in cities for decades, but I grew up in the mountains of Tennessee. I'm the daughter of a rural healthcare worker, and I know firsthand the gaps that exist in access to care between these two worlds. So last week at the Fortune Brainstorm Conference, I was pleasantly surprised to meet a tech executive trying to solve for some of these problems. I'm Jennifer Strong, and this is Shift.
Now here on the steering column is a device called Auto Cruise. You simply set the speed you want.
Self-driving robo-taxis are already on the road in 2 U.S. cities.
As the disc rotates, a mirror reflects the light in the way that depends on how the signal was recorded.
This is the 100 terabyte I present to you Electro, the Moto Man.
Ladies and gentlemen.
I would say that one of my greatest skills is my ability to interact with humans.
This episode, it's the latest installment of our oral history project. How do you collaborate with AI? Miro's Innovation Workspace is an intelligent platform that brings people and AI together in a shared space. Teams can work with Miro AI to turn unstructured data, like sticky notes or screenshots, into usable diagrams, product briefs, and data tables in minutes. And you can quickly build on your ideas without needing the perfect prompt. The work you're already doing on Miro's canvas is the prompt. Help your teams get great done with Miro. Check out Miro.com to find out how. That's Miro.com.
From Zuckerman Spader. For 5 decades, Zuckerman Spader has been a leading litigation firm trusted by in-house and outside counsel, businesses, and individuals. With offices in Washington, Baltimore, New York, and Tampa, Zuckerman Spader serves clients throughout the country and around the world in high-stakes disputes, enforcement matters, investigations, and at trial. When the lawyer you choose matters most. Online at Zuckerman.com.
We have to be very precise about who it is that we're building for, because in healthcare, there are so many factors outside of the technology and the clinical science that ultimately dictate whether people get healthier or not. My name is Amar, Kendale, and I'm the co-founder and president of Homeward Health. So Homeward is a company focused on transforming rural healthcare and really bring rural communities along in the way that the rest of America is benefiting from technology and its impact on health. This is a moment where I think it's possible for the first time ever, where, what had been a liability is you just don't have enough doctors could actually be an asset, because in rural environments, you are actually not disrupting very much. So there's an irony to this. And I think it opens up this potential for a leapfrog phenomenon. I'll give you a counterpoint. If you look at like a mature market, where I'm from in California or where you're from in New Jersey, there's many providers. They're often very well funded. They're often adopting technology at a breakneck speed. They have any number of systems that they're running. If you come to them and say, hey, I have a new technology for you to try, they'll say, I'm going to put you in the queue. And maybe we'll get to it at some point. By the way, it has to work with these 10 different systems. Ironically, if instead you go to a rural hospital in Mississippi and you say, I have a technology for you, it's going to save you money, it's going to make your doctors more productive, and it's going to be great for the patient. They actually stopped listening after you said it's going to save them money, because that's actually the first problem that's on their minds. But they love the fact that those other things are also true. And there's nothing to disrupt. They maybe have an electronic health record, but honestly, no one's come to call on them since that was put in place. We liken it to the phenomenon that we've seen in the developing world, where you have, entire countries that have gone straight from, no phones to cellular, right? Or coins to mobile payments, right? In some cases, those are ahead of where we are in America, right? And it's because we have so much infrastructure that's kind of in the way. So my belief is that rural America is poised to adopt a lot of these emergent technologies in a way that could make them the first and best adopters, because they stand to benefit and there's not a lot to disrupt. There's not a lot, holding us back from getting these technologies into their hands. So my business partner, Dr. Jenny Schneider, and I took a very analytical approach as we were thinking about the next chapter of our work together, and considered where in America are there really meaningful disparities and places where technology can play an outsized role. We're both technologists and have had a lot of experience seeing the role it can play. We've been able to deliver a lot of benefit to employees of companies who are living with chronic diseases. And those same sorts of approaches applied to different problems we believe can also drive tremendous benefit. As we were exploring a variety of different angles, we considered the fact that pharmaceuticals are not really paid for on the basis of how well they work. We considered the fact that specialty care is very difficult to access in remote places because you don't have specialists. We considered the fact that this idea of value-based care is very difficult to bring to places that are not as mature and evolved in the way that their care models work. Each of those factors, as we considered, where is this having the most negative impact, our answer kept coming back to it's rural America. And as we dug into the data, we found it was showing up in the outcomes. So we saw a 23% higher mortality among rural Americans relative to their suburban and urban counterparts. And we found that some of the reasons for that were a significantly less access. So 50% as many primary care doctors, and that number is declining. An eighth as many specialists, and that number is declining. And then just about every week we see in the headlines a story about a hospital that is at risk of closure. So these local institutions that people have come to rely on just aren't going to be there in the way that they had been. So that started to give us a sense that this was a scale of problem that really needed attention, and that there was a lot of nuance that we needed to understand in order to start to build. A lot of the conventional wisdom around why things were the way they were fallacies. And our approach has been, in order to do anything at a meaningful scale, you have to align financial incentives. So we decided to commit ourselves early to a value-based care model orientation. Secondly, we decided, as I mentioned, that technology was going to need to play a significant role. And thirdly, we decided that we needed to establish a really robust local presence in order to understand what it was that people were actually experiencing. So in the early days of Homeward, that's exactly what we did. We found payer partners who would collaborate with us in a value-based care format. Payer partners like a health plan. These are the folks who, in the case of Medicare Advantage, which is where we focus, it's the government that actually pays the money, but they've essentially subcontracted to these health plans. And one of the things that happens when you work with a health plan is you can create some flexibility in the way that you deliver your model of care. So by adopting value-based care, which is a world in which Homeward takes on financial risk, we're delegated financial risk from this health plan, and we're given that responsibility for a whole population. So it's very high stakes. It means that we are only successful if our patients are successful, if their healthcare costs are managed effectively. And our underlying belief is that the only way to manage those healthcare costs successfully is to make this population healthier. So that's the concept around financial incentives. And it does mean that we create a degree of freedom for ourselves in the way that the care model can be constructed. So in a traditional care model, if you're a provider, you might work with a health plan in what's called a fee-for-service model. You get paid for doing the work. In our model, it's different. And so because we don't have to worry about that idea of, patient has to show up, I have to spend 15 minutes, that's the only way I make money. Instead, we can think about what is the optimal way to distribute these resources? What's the right time to reach a patient? Maybe it's by phone, maybe it's by video. Things that you traditionally wouldn't get paid for become possible in this kind of model. So this question of how do you use technology to actually solve the problem? Because you don't have enough resources, but you need a local presence, you have to do the best with what you have. And so our solution there has been to upskill the local workforce, but to focus on the workforce that is there and going to be there for the long run. And so think about in the medical field, there's a lot of lower level folks who are very capable of being that bridge. So we hire medical assistants, we hire community health workers, and the role they play for us is that they're navigators. And a navigator has this really interesting responsibility of being from the community. They will work directly with our patients, but they'll also work with community partners. They'll work with, for example, the local VFW or the church group or whoever might be willing to support seniors, and things like arranging for Meals on Wheels or transportation to a visit. And so those are the kinds of resources that unless you're in the community, you would never uncover. So our navigators do this really amazing job of being that bridge. They're not only from these communities, they want to stay. They really want to serve the community that they're from. which is different from looking at what happens on the higher level medical professionals. And so in those cases, what we've learned is we have to import capacity. So those two ideas, upskill the local workforce and then import capacity from outside the market, because there's no other way, is the other use of technology. So in this case, we use telemedicine, but more importantly, we use data and how we assemble that data and how we make that available to our providers, how we construct a relationship between the patient and that provider with the navigator as the bridge has really been the key to the kinds of success that we're seeing now. When you think about what might a navigator do or what kind of role does navigation play, it's the way we address these social barriers, the barriers to health, sort of social determinants, these be called, that ultimately for a lot of rural Americans are the reason they don't get care. It's not just access, or rather it's access, but it's more complicated than just whether is there enough doctors. For a lot of folks, it can be as simple as I don't have a ride, and you're in a place where there's no public transportation. So those are places where the role of AI has actually been really substantial, and this idea of giving our navigators superpowers and making navigation as a concept abundant as opposed to scarce. That's a big unlock for us. And so imagine you have a co-pilot, as you're working with a patient that's giving you suggestions about here's how you might be able to solve this problem or that problem. That's a big efficiency driver. It's also a way we extend our reach. On the clinical side of things, imagine that same kind of capability that's giving your provider, and for us, a provider who we employ will be typically a nurse practitioner, a physician assistant, and we want them to have superpowers too. So that's everything from scribing to take notes during the visit. It's suggestions for questions to ask. It's ways for us to follow up with a patient and make sure that they're participating in the plan of care. So those are places where we can drive a lot of efficiency into the model that ultimately benefits patients. So when you put those together, I think, what we think a lot about is we can arrive at a model of healthcare resource abundancy that is really unprecedented.
Now more than ever, organizations need to unleash the potential and the power of their people and AI. Miro's Innovation Workspace is a faster way for teams to turn good ideas into great results. It helps teams accelerate through the full innovation cycle, helping them get from idea to outcome faster. It saves time, it's easy to use, and it's actually fun. For a podcast like mine, we can use it for road mapping. That is, outlining a product plan over time in a visual way with key features, milestones, and release schedules. We can also use it to work on new show concepts. Miro has been empowering teams to transform bold ideas into the next big thing for more than a decade. Now, they're at the forefront of bringing products to market even faster by unleashing the combined power of AI and human potential. Here's how. Teams can work with Miro AI to turn unstructured data, like sticky notes or screenshots, into usable diagrams, product briefs, and data tables in minutes. It's more than just putting a bunch of ideas on a board, and you can quickly build on your ideas without needing the perfect prompt. So you don't have to be an AI master or play with yet one more tool. The work you're already doing on Miro's canvas is the prompt. So you can quickly build on your ideas without needing the perfect question. Help your teams get great done with Miro. Check out Miro.com to find out how. That's Miro.com.
We today serve over 100,000 patients in Michigan. So we are all over the entirety of the Upper Peninsula, which is really as rural as America gets. And we're covering a substantial portion of the Lower Peninsula, which is similarly full of health deserts, where there are entire counties without a single healthcare provider. And as I mentioned, we've partnered with the health plans in those areas. We've also partnered with the local providers to collaborate on the care of the patients that we co-manage. We don't disrupt the relationship that a person has with their doctor, but we look to augment it. So these resources I was describing, whether it's our navigation services, whether it's our advanced practice providers, they're really designed to supplement whatever a patient has. In some cases, a patient has a decent sort of environment. Perhaps their needs are going up and they're starting to need more than their primary care doctor can offer. In some cases, these patients have nothing. And so, just in rough terms, if you think about 100,000 people, that translates to, roughly $1 billion of revenue in this kind of value-based care format. But the nature of this problem, as I'm describing it, shows up in every single one of the 50 states. There's some substantial differences in the way that it shows up across these different markets. Sometimes it's because the providers behave differently. Sometimes it's because the health plans behave differently. Where we are going to be expanding into is the rural Southeast, Georgia, Mississippi, Louisiana, Alabama. AI scribing, has been demonstrating the fastest rate of adoption among providers of any technology ever. Here's a case where for the first time, providers actually are directly benefiting from a technology because it gives them time back. So instead of having to write their own notes, oftentimes after work, now in real time, an AI scribe can listen to what's happening in the visit, transcribe it, translate it, summarize it, make it really usable, so that a doctor has to just review it, confirm that everything's accurate, and be on their way. It's a gateway. It's an opening into something that now allows us to introduce more functionality that not only summarizes what happened, but also provides insight, provides context, provides evidence, so that provider can be armed with more information than they ever had before. Things that used to take weeks can take minutes, and that's going to result in better patient care. The reason we feel so compelled by what that's going to do for patient care is because there's also some very near-term financial benefit. So the idea of how these technologies get adopted is that it has to be doing good things for the doctor, and it does productivity-wise. But the next good thing that it does is it actually creates a documentation trail so that when it's time to do billing, a lot of the documentation is taken care of. So the administrative benefit's real. We actually think that is going to be the way that these technologies make their way into our less advantaged hospitals and health systems. So where we do our work in rural areas, that's who we're talking about. We're talking about folks who need an immediate bottom line impact in order to be able to make these investments in things that improve patient care and provider experience. Where we go from there, I think there's a lot of different directions. I think we will arrive at places where there's better and better clinical decision support for providers. No doctor would acknowledge that they're in the bottom 50% of doctors. What does it look like for us to raise the floor, right? And really make it possible for all doctors to be good doctors, if not great doctors. The second big, I think, aperture that opens is the way that patients can do more themselves. They can self-serve in ways that are more trustworthy and reliable thanks to these technologies. How this works the best is if it can be truly personalized, if it can really speak to a patient in their own language. And that could be anything from grade level to your local environment, to the conditions that you're living with, the social factors that surround, the way you live your life. The more personalized those can be, the more actionable the recommendation. And then finally, there's, I think, a series of things that we can only probably at this point imagine in terms of the way that these technologies can be applied. But what does it look like if we could have an EMT perform a surgical procedure? Not because that's the optimal, but because in some cases that's what's needed. And I think we're making our way towards a world with a combination of augmented reality and real-time coaching and support. That's something that is going to be not just possible, but likely necessary for some of these communities that we're talking about, where the resources simply aren't available in any other way. And so I believe that will take us to a place where we can save lives, on the frontier.
This episode was produced by me and Emma Cillekens and mixed by Garret Lang, with original music from him and Jacob Gorski. Thanks for listening. I'm Jennifer Strong.